Good afternoon, everyone. Thank you so much for joining us here today for our special webinar series, Expanding Access to Recovery. We're really excited to have all of you here. So we'll go through a couple housekeeping issues before we get started. I want to make sure that everyone feels comfortable and confident as they navigate through GoToWebinar here on our series today. So the way GoToWebinar works is everyone will initially be muted and you won't have the opportunity to unmute yourself. And we do this because we have a large amount of attendees who have dialed in here. And so that way, not everyone is talking at once, and we'll continue to have audio for our presenters who are currently on screen, and we'll go from there. In the meantime, I want to make sure that you all know that there's a chat box as well as a question box. If you have questions through this experience, please make sure to use the chat box in your control panel, and I will be paying attention in the background performing technical assistance. And so if you have any questions, I'll make sure that they get answered while our presenters are communicating with our audience here. And with that, I will hand things over to Patty McCarthy.
Great, welcome everyone. It's nice to have you all on our webinar today. My name is Patty McCarthy and I'm the Executive Director of Faces and Voices of Recovery. And we've launched a National Recovery Institute Training and Technical Assistance Center. So this webinar is one of many opportunities you'll have in the future to receive training, technical assistance, information about recovery support services. So I just first want to thank Keegan Wicks, who just introduced us the webinar, talked to you about the GoToMeeting platform. Keegan is a project coordinator with Faces and Voices of Recovery. But to tell you a little bit more about this webinar, we have been discussing as these national organizations that are providing recovery support services, how to get the word out more about what we do, what the infrastructure looks like across the country for recovery support programs. These programs have all emerged as critical components of a comprehensive and effective approach to addressing addiction and promoting long-term recovery for everyone. So our goal is to have an overview of each of these national recovery infrastructure components. We will present from our particular component of that infrastructure, and talk about how each of these organizations started, what they do, and where they're going, where they're in the future, and how much they're doing to support people in recovery now. So our panelists today, we're going to start with Rebecca Bonner, who is a board member of the Association of Recovery Schools. And then we're going to hear from John Cates, who is a board chair of the Association of Alternative Peer Groups. I will then present about the Association of Recovery Community Organizations at Faces and Voices of Recovery. And then we'll hear from Tim Rabel, who's the Executive Director of the Association of Recovery and Higher Education. And lastly, we'll hear from Dave Sheridan, who's the Executive Director of the National Alliance for Recovery Residences. So throughout today's presentation, please feel free to type your questions into the Q&A box that you see. We will respond to all of those questions at the very end after our presentations, so we can make sure we get to all of your questions. So I'll now turn it over to Rebecca.
Okay, thanks, Patty. Let's see, can we go back? Yeah, thanks, Keegan. And back to Mission, actually. There we go. Thank you very much. First, I have to say I'm at home, and it was a question between having distractions from the students or having distractions from the dogs. So I am at home with the dogs, and hopefully that won't interfere too much. As Patty said, I am a board member of ARS. I've been on the board since 2014. And since 2011, I've been the director of the Bridgeway School, which is the first recovery high school in Pennsylvania, and serving largely southeastern PA, Philadelphia and the surrounding suburbs. But today, I welcome the chance to talk more about ARS. I know that all of my colleagues in ARS, we far too often hear that we're our city's best kept secret. And we're really trying to do what we can to make sure that we're no longer our area's best kept secrets. The mission of our ARS is to support the establishment and maintenance of recovery schools. And we do this by providing technical assistance to people who are starting up, accreditation standards for people who are running schools. And that's really our vision, is to make certain that every student in recovery who wants and needs a recovery school has access to it. Okay, thanks. So a little bit about the history of ARS. In 2002, SAMHSA had a small grant in order to convene about 10 people from around the country who are working on developing recovery schools or currently running them. These are people who had largely no idea that other people were doing it. I have only heard the stories, but I hear that they were strong and passionate people. And I think probably that picture is not a very adequate representation of what actually happened at that early meeting. They were really talking significantly about the life and death of students and how they could best make sure that students, teenagers, could have access to recovery supports in order to sustain their sobriety. I just wanted to say there's Andy Finch, who I'll mention a few times in this presentation, is out of Vanderbilt. He's writing a book about the history of ARS. And he will probably talk a little bit about a fist fight that nearly happened at that first meeting. So the organization originally served both secondary and post-secondary students, but there was an evolution in about 2011, and Tim might have the actual date on this. The collegiate programs and the recovery programs split, and that was largely because the programs were exponentially different. So we still, though, do a joint conference annually, which is nice because we can get together and talk about that transition from our high school students onto the collegiate programs. ARS now has about 50 member schools, and we've been adding about 2 to 3 schools for the last couple of years. Research has always been very important to us, but most of our energy, money, time has gone into, all of our resources really have gone into starting schools. So we're playing a little bit of catch up in this area, but I'll talk a little bit about some recent research that is able to document and demonstrate that the impact that recovery high schools have. So what is a recovery high school? A lot of people have a sense that they know sort of what it is, and Association of Recovery Schools has really done a very good job of mapping what it is that makes a recovery school. Because there are a lot of programs out there that will say that they're a recovery school, but according to the ARS, we might not necessarily view them as such. And so these requirements, these kind of identifiers on this slide are what makes a recovery school according to the definition of ARS. The primary purpose of a recovery school is, as I said, is to provide a state-recognized academic program for students who are committed to abstinence. We do recognize that there are many pathways to recovery, but we're dealing with high school students. They're largely minors, often part of the juvenile justice system, and therefore what we might call harm reduction practices really aren't applicable to our student population. In the early days, most of our recovery programs worked by our students were 12-step based. That's changed a bit over the years. All of our schools require that students work a recovery program, but it looks very different depending on the students. Some still do 12-step programs, some do SMART or refugee recovery, some are working more wellness-based programs, some their recovery program is faith-based. So, it's their youth groups, for instance. And finally, in order to be a recovery high school as defined by ARS, the school has to be available to any student who wants it. For example, it can't be attached to a treatment program and only open to the residents of that treatment program. So why do recovery high schools work? you know, this is an area that we are working more to get evidence on, but we know some anecdotal things and some not so anecdotal things. NIDA came out with a study several years ago that, you know, we know now that 8 out of 10 students about who return to their prior high school will have a recurrence generally within the first 6 months. That's 8 out of 10 students within the first 6 months. If there's any kind of co-occurring disorder, and this is statistics out of the Treatment Research Institute, any kind of co-occurring disorder, anxiety, depression, bipolar, the median time to recurrence is 19 days. So what recovery schools do is they step in very quickly after treatment, or in some of our students' cases, juvenile detention somewhere, someplace where they've been able to cobble together some significant abstinence. We know that if we can get them into school and work to remove some of those triggers, they have a much better success at maintaining long-term recovery. This is important too, because a lot of people will say, well, why don't they just go to another school? You're removing them from their prior environment. Can they go to another school? There's something we like to call the Starbucks phenomenon, and I won't take credit for this. Andy Finch gets the naming rights to this, but he tells a story about being in an unfamiliar city and wanting his morning Starbucks. He goes out the hotel doors, and it takes him a total of 90 seconds to locate the closest Starbucks. And as he points out, our students are much, much better able to find those connections within a new school of where they're going to be able to get those substances. So in the absence of explicit recovery supports, it's very difficult for kids to maintain their sobriety. So recovery high schools provide those recovery supports. And the most important one, I would say, and I think most of us would say, is the positive peer pressure. Students supporting each other and holding each other accountable. So Andy Finch out of Vanderbilt and Paul Moberg out of the University of Wisconsin, they have been directing almost all of the research that has to do with recovery schools. Some of it's been looking at just characteristics within populations at certain schools, but this was the first study that actually compared students who attended a recovery high school post-treatment versus those who had treatment and did not attend a recovery high school. As you can see from this, after 6 months, the students who attended the recovery high schools were significantly more likely than the students who did not attend to report complete abstinence from alcohol, marijuana, and other drugs. They exhibited lower levels of marijuana use, and they have less absenteeism from school. This was a very small sample, I will say that. More research is needed, but we feel great to be finally getting these kinds of numbers out there that can demonstrate the impact of attending a recovery high school post-treatment. The last few years, we've really had a push to accredit more of our schools. We've developed a rigorous standard for our school design regarding curricula, recovery supports, and sustainability. And now our focus is really on getting the member schools that we do have to get accredited according to the ARS standards. Right now, our capacity is limited, and we can't really accredit as quickly or do as many as we would like to do. We don't have an executive director. The only people we have trained to accredit are us board members, and we are all running schools or working on other programs, and our time is limited as well. This is severely hindering us. At the same time, we think it's just incredibly critical to our growth. So funding to increase our capacity in that area is one of the things that we are focusing on so that we can more quickly, help schools form and accredit them and get them recognized as such. It's an interesting thing. We have, I'm sorry, okay, so I just want to say I'm almost done, and Keegan, I think you took control of this, which is fine. But I just wanted to say that research is another important thing that we want to be focusing on, because that one little study that we have is basically it at this point. So we're looking to increase our capacity to accredit and increase our capacity to do research. We want to make sure that adolescents are getting the supports they need, because we all know that the stats out there that you know, 90% of adults who have a substance use disorder picked up between the ages of 12 and 17. So we believe that intervening early is going to just improve everything. And we want to work to get the kids into collegiate recovery programs in order to get that 5-year of sustained recovery to increase their chances of a lifetime without addiction. That's what I have. And please, if you have any questions, I know we're not doing them till the end, but please feel free to jot them down and we will address them at the end. And I'm going to turn it over to John Cates now.
Can everybody hear me? Okay, I hope they can. I'm assuming they can. Let's see. And I hope I can be seen. Hello, hello, hello. I'm John Cates, and I have the honor to follow ARS and the privilege. A little bit of my background, it goes back about 43 years. And the first thing I did professionally in the field was, according to Andy Finch, Dr. Finch, was open the first freestanding recovery high school in 1976. It's not by accident that I'm the old guy today, because I am the old guy. I am here for the Association of Alternative Peer Group Program, and the reason why it goes back 1976 is everybody hears peer recovery, peer groups, peer recovery, those kind of things. Well, what a lot of folks don't know, but it's becoming more and more informed out there, is that peer recovery actually has existed in Houston, Texas since the early 70s, right at 50 years. It started with a program called Palmer Drug Abuse Program, and I, in my own sickness, needed help and got it in that program. That it was not called Alternative Peer Group Programs, but now it is. A lot of people think that APG, which is the term I'll use, it's a lot to say Alternative Peer Group Program, but APGs are all about adolescents. But the facts are, for 50 years, these programs have been working for young adults and older adults, over 25-year-olds also. So as I talk, yes, what's most known out there about APG programs is what's going on with adolescents, and that's due to a film that was made. But in fact, there have been for many, many years, these APGs have been used with young adults and adults as well. Here's the part where I try and change my slide. Let's see if it works. Let's see. Not so far. Ah, there we go. Today, I just wanted to go, I kind of already went over the general history of alternative peer group programs. I will tell you that they became huge. By 1979 in Houston, Texas, just in Houston, Texas alone, there were 3,700 young people in Palmer Drug Abuse Program. In 1985, a second program opened up called Lifeway. By 1992, Lifeway was in 11 cities in the United States, 3 in Canada. The programs are actually organized approaches using peer recovery. And they will have, in certain cases, they'll have their own residential programs, their own IOPs, as well as the alternative peer group programs that go on. And I'll get more into that in a second. But by 1992, Lifeway was, as I said, in 11 cities in the United States, 3 in Canada, had 4 of its own residential programs. We call them hospitals at that time. Had 4 high schools, 4 recovery high schools at that time, all of them under the Lifeway banner. And there have been a lot of other programs since then. Here in Houston, we have 5 different alternative peer group programs. What has come out of this 50 years is a collection of how to build the systems to use peer recovery, how to use it at its optimum. And we also do training on helping organizations who want to build these alternative peer group programs and how to apply all of the things we've learned over this 50 years. It's an accreditation process, but it is definitely a development process and not a checking. if you want to learn how to do it, we'll talk a little bit more about that. If it makes sense to you that this is something that we should want to do, then please let us know. Let me tell you what the real bottom line, if I can get the slide to change here, the real bottom line to what we're trying to do is, trying to change the slide there. One of the things I want to, if you'll look at this photograph, that was about 1979. Well, there's a lot of people in that program in Houston, that alternative peer group program in Houston. The thing I want to point out to you, though, that that is not a picture of people who are in the program. That is just staff. That's the staff that worked with the 3,700 people. Notice over to the left, this staff was trained. They were trained already in peer recovery. It was a very hard training program. There were 4 months of 10 hours a day, 5 and 6 days a week. They were weekly feedback on how you were doing. It was all organized. You touched every different kind of program, whether it was adolescent, whether it was in the hospital, whether it was at juvenile probation, and there was a trainer that trained you. They took back feedback to the evaluation committee on how that trainee was doing, and it went on for months. So there was training on how to be a peer, what we now call peer counselors. These guys were paid. These were not volunteers. These were paid folks who were working within a unit, a gigantic unit that was treating 3,700 people just in Houston. There were 1,800 more in Dallas at the time, by the way, with a staff almost that same size. They were professionally accountable. Every 2 weeks, there was a meeting we called Purpose, and it was a place where you went and you talked about troubles you were having, how to fix them, and those kinds of things. Also, these organizations worked with all different cultures and still do work with a lot of different cultures. In 1997, Lifeway had the largest Medicaid-driven program, all alternative peer group programs, and it was paid by Medicaid. There were in Houston, Texas, 1,800 Medicaid, and they were in low socioeconomic areas and diverse places. So these programs are organized, they're trained, they have a lot of experience. They work for all different ages, and I'm trying to get it to change again, if I could get the slide to change. There we go. So what is research? Why do we build these things? And why do they show that they're effective? Why is the peer movement showing great effectiveness compared to not using it? Well, what's the research say about the disease? And the APG programs are based on the research. It doesn't say 30, 60, 90 days. It says 18 months to 4 years to stabilize. It says if you approach things and keep continuity of care and accountability in place for that period of time, your success rates go up. The research says if you involve families, that's going to make your success rate go up. It says if you can change your friends and adopt friends who are succeeding in recovery, that your success rates go up. And it says that accountability is important. The reason why pairing alternative peer group programs with recovery high schools is so powerful is because of this accountability. Peers are there. Families are involved in the alternative peer group programs. They're looking at 18 months to 4 years, not 30, 60, 90 days. They're looking at a realistic idea of how to treat substance use disorder, and they keep it continuous. If somebody has trouble, instead of counselor hopping to new programs saying, oh, well, that didn't work, they're involved in trying to decide what was it that I need to change. And that accountability and continuity of care is real easy. Change my slide again if I could. All right, this is the typical standard non-integrated approach, and the best way to understand an alternative peer group program, what we've learned over the last 50 years, this is what we're doing right now in the nation and what we've been doing ever since we've been treating this disease. If you'll notice, we've got all these different elements that go on. We've got, you're using, you go to a counselor for a little while, and then, you go to a hospital or, for detox, and then you come out and you go to something else, then residential, then, you're having trouble with school, so you go back, as my predecessor was saying, you go back to your regular school. That didn't work, so now we go to another counselor, maybe another hospital, and it's all broken up. Nobody's talking to each other, nothing's happening. And you end up with multiple admissions to intensive outpatient, residential, and hospital programs, not to mention if you're lucky enough to have schools there, that the schools. Need another slide, please. In an APG, this is what happens. When you're using an alternative peer group program, it keeps all of it tied together. And notice the incidents diminish. And that's the whole idea behind using an APG. You have substance abuse issue tracks. You have mental health tracks that can also all get mixed together. And it works. These things have worked for a long time. And there is research to say it. It comes under not only research about alternative peer groups, but it also programs. It also comes under research about wraparound, continuity of care, length of stay. All of those things point to what we've been doing for the last 50 years is a real good idea if you want to try and treat substance use disorder. Next slide, please. So it sounds really like a big deal and like it would take a big deal to get it going for adolescents, young adults, or adults. It actually is not that difficult, and the Association of Alternative Peer Groups is designed to try and make it easier and simpler. Because of that, we have now about 30 different alternative peer group programs around the country at different stages of development. The APG, the AAPG, the Association of Alternative Peer Groups, is available at this phone number and this website. It does not require that you have massive resources. It can be as simple, and several of our organizations who became very, very large actually began as just finding a room that could be used for 2 hours, or a couple of rooms rather, for 2 hours a week, and a talented person to learn the process. If you're interested in learning more about this and how to do it, getting the support you need and becoming a part of this association, then here are the numbers right down here. Don't hesitate to call. Let me see. How do I change this slide now? All right, and that is me. Now I get to introduce Patty McCarthy with ARCO. Patty, you're on.
Wonderful. Thank you so much, John. This is great. Following my colleagues here. They're doing amazing work. Let's talk about Faces and Voices of Recovery and ARCO. I'm going to mostly talk about ARCO. But the role of Faces and Voices as a national advocacy organization is to mobilize and organize the recovery community and demonstrate that over 23 million Americans have found recovery, and that recovery, long-term recovery, is a reality and a process that takes time and support. So here you see us last year on Capitol Hill, on Recovery Day on Capitol Hill, and we every year organize an event where we can meet with our members of Congress and talk about recovery and what's needed across the nation to help people succeed and sustain long-term recovery. Next, we will talk about ARCO. So in 2012, we formed an association because what we discovered, there were lots of organizations out there that were doing grassroots recovery support services in their own communities or as a statewide voice of recovery. So we formed ARCO, so all of these organizations have joined together as a network with a common voice of advocating for recovery support services, putting a face and a voice on recovery in their own communities. And so now there is a statewide network with over 150 organizations around the country. And so as a network and as an association, what we do is we work with our staff at Faces and Voices, work with those organizations to inform them of policy issues on the national level, help them with resources around providing recovery support services, technical assistance and training, provide toolkits on things like Recovery Voices Count or how to organize a voter registration campaign. We have other toolkits that we provide, such as how to host a community listening forum. And we have the RCO toolkit, which describes how to start or organize a recovery community organization. So there are, and we have a map on our website that you can go to, and you can, there's like a drop-down menu where you can look at your state and see where those RCOs are. As you can see, probably the East Coast has many more. In Georgia, there's over 12 that are members of ARCO, and a number of other ones growing there, forming. Pennsylvania, we have 10. Texas, there's 8. In California, there's 6. So there is a way to find out where a recovery community organization is near you. There's also different varieties. There are RCOs that are statewide advocacy organizations, and they may not be providing direct services or recovery support services in their communities, but they are helping the recovery support providers across the state with things like training and technical assistance and advocacy and convening conferences, meeting with state policymakers, hosting recovery rallies and recovery days in their own state houses. So that's the role of a statewide RCO. And then the local RCOs, many of them are providing recovery support services. We'll talk about that next. Let's see. Okay, so a definition. What is an RCO, and why are we talking about this? You know, the national network and how important they are in a continuum of care, a continuum of services that really needs to exist in every state to help individuals, you know, find long-term recovery. It's because these are the organizations that are independent nonprofit organizations. They're led by people in recovery, the local recovery community, they're grassroots. They focus on one of 3 things and any combination of these 3 things. So they may be organizations that are just providing policy advocacy organization activities, but they're the truly authentic voice of the recovery community is represented. And then there are programs that are doing outreach and education programs, and RCOs that are conducting those types of activities like you know, naloxone training or stigma reduction campaigns or training peer recovery coaches. Those are the types of community education and outreach programs that might be conducted. And then there's those that are providing peer-based recovery support services. So many of these RCOs operate an actual recovery community center, so a building, a place where people can come. It's the hub of the recovery community, we call it, where they could come in and look for how to access jobs, how to go back to school, how to find housing. They may meet with a peer recovery coach. Many times these peer recovery coaches are housed or employed by the recovery community organization, but they're contracted to go out into the community through, they might be working at a drug court. They may be working at an emergency department or at the local DCF in the child welfare agency, or they might be working with housing providers. But this is where they can find that support of other peer recovery coaches and receive appropriate supervision and training that is truly based on standards and best practices. So let's talk about what the standards are for an RCO. At Faces and Voices and with ARCO, we developed national standards for recovery community organizations. So they need to meet all of these criteria to be defined as an RCO. These are, again, they're nonprofit organizations. They're led and governed by the recovery community. Their primary focus is recovery from substance use disorders, although they may also serve and support people with mental health conditions, criminal justice histories, various other issues, but the primary focus of that organization would be reflected in its mission, that it is focused on recovery from substance use disorders. It's also a grassroots. So it comes from it's grounded in grassroots advocacy and grassroots movement. So somewhat of a, based on a social justice movement that these organizations are stepping up to the need in the community to respond to a crisis or to respond to people that just don't have anywhere else, or they need help, and the people in the community are the ones that have come together. They can be, not working in this field. They can be family members, they can be friends, they can be business owners, but it's grassroots. They've all come together to make this RCO successful. That it's a participatory process, that they're inviting input and guidance from the community, and most importantly from the people that they serve, so that the people that they serve, the participants in the program, have mechanisms, ways to give feedback, whether they're on an advisory board or have a quarterly meeting where they give feedback, those type of things. And also that they're non-clinical services. So RCOs do not provide treatment, or they do not provide assessments or any counseling. We hear the word peer counseling, and when you hear that, it is not clinical, it's non-clinical. It's not necessarily, I wouldn't use the word peer counseling, but peer-to-peer support. But when you hear that in an RCO, it's non-clinical services. So they're not trained to be clinicians. These RCOs support all pathways of recovery. So they may have come from, say, a faith-based approach or other pathway, but they need to respect and allow for folks in all pathways of recovery. So whether they're in medication-assisted recovery or, like I said, faith-based or 12-step, whatever pathway that these organizations are open to and support those folks, whether they actually provide all of those is case by case, but they are certainly not discouraging of other pathways. And then lastly, that there is recovery-friendly language that's used at these organizations, meaning we use language that eliminates the stigma and puts a positive face on recovery, that we are people in recovery, person first language. Next. Oh, did I go? I went too fast. Can we go back, Keegan? So I just want to mention also that the Council on Accreditation and Peer Recovery Support Services is also a program of Faces and Voices of Recovery. So there's a lot of work being done, just like in our in housing and in recovery schools, to accredit organizations that are providing those services. And so in the peer recovery support services, there is an accrediting body that was developed to help these new and emerging peer programs to build their capacity. But they help to improve the performance of these programs based on a set standards, set national standards for the delivery of peer services. And ultimately, this increases the accountability of these peer providers, the RCOs, to funders and the public and the field. So overall, what our goal is to demonstrate the effectiveness of the peer services that are provided by recovery community organizations, to be accountable to funders, to be accountable to the public, and to be a critical component of the system of care in every state and in every community. Next. Just a couple slides on what we're aiming for. So in order to sustain the system of all of these parts of the recovery support services structure, we need to come together as a strong voice to advocate for substantial new funding for recovery support services. There are just no dependable, sustainable funding mechanisms out there, whether it be through state block grant dollars, Medicaid dollars. Many organizations struggle each year to fight for and apply for the grants that come out, but they're not long-term, they're not sustainable, and until we have a sustainable system, we're just not going to be able to really turn the tide on the epidemic that we're facing today. So that's folks on our team and some RCO members that were at the State House last year during our Hill Day advocating for recovery funding. And some of the priorities in our legislative priorities are, the next slide, is to increase what the states receive every year. So there's a dependable source of funding for the states every year, and it's through the Substance Abuse Prevention and Treatment Block Grant. That is consistent. It's been there for lots of years. They get it. The states use it for prevention, treatment, recovery, support services. I added this slide to tell you that this is recent language. It just came from the congressional justification language on the block grant. And then SAMHSA said that it encourages the states to use their block grants to allow pursuit through personal choice and many pathways of recovery. Asks providers to assess their performance and based on outcomes and client success. And then what we thought was really important was that they said expand capacity by increasing the number and types of providers who deliver clinical treatment and or recovery support services. So we need to see this increased, and we need to see it dependable in order to support this whole infrastructure of recovery. And as you see, that there is no increase, even though there's been lots of advocacy to increase it. It is not in this year's continuing resolution, or this year's funding for appropriations has not been increased. It's level funded again. So just wanted all of our viewers to be aware of what's going on and where we're heading. We also, as the ARCO and Faces and Voices, have had a strong belief that there needs to be a set aside, a certain amount of the block grant dollars that should go to recovery support services. We are advocated for 20% of that block grant. Currently, there is a 20% set aside for prevention in the block grant. So all the states they all receive a set amount of block grant dollars, and 20% of that amount has to go to prevention. And we're advocating for that 20% to go towards recovery support services to fund what we're talking about here today across this continuum of recovery community organizations, recovery high schools, recovery collegiate recovery programs, housing, all of the recovery support services that make communities ready to respond and to help people in long-term recovery. Next. Oh, and just some resources. So in order to advocate, we need to have documents, we need to have infographics and things like that. So please visit our website and look for ways that you can get involved in helping us to sustain this growing infrastructure of recovery support services. And next, I'll turn it over to Tim. Fantastic. We have Tim Rabel from Association for Recovery in Higher Ed.
Perfect. Thanks so much, Patty, and thank you everyone for joining too. It looks like you have over 100 attendees, which is really exciting. First, I just want to say thank you again to Patty and Keegan and Faces and Voices of Recovery for putting this together and hosting us. For me, it's really exciting. It might be the most kind of exciting topic in this space for me personally, just talking about, you know, the full kind of continuum and discussing how to really build this national recovery support infrastructure that truly will be, you know, kind of supporting and helping the kind of the greater good for years to come. It's something I feel like we're going to look back on and really feel like everyone that's a part of this was really a part of history, kind of in the making. And I don't know what everyone's role is on the phone, whether, you know, you work at a RCO or a recovery high school or just interested in the topic, but even just, you know, being on this webinar today and learning about it, you know, plays a good role kind of in this overall movement. So it's really exciting. As Patty mentioned, my name is Tim Rabel. I'm the executive director for the Association of Recovery in Higher Education, kind of known as the Collegiate Recovery Association. We represent colleges and universities across the country who have collegiate recovery programs. We abbreviate them as CRPs, so you might hear me toss around that term from time to time. So we represent those institutions, but also, you know, the staff, students, alumni. We have corporate and nonprofit members. It's really exciting to kind of see this whole the collegiate recovery field specifically grow from kind of the early days. So about ARHE, you can see on this slide, you know, our mission and vision. We'll get into some of the other kind of details as the slides go along, but you know, really we're there to support the kind of growth and development of the collegiate recovery field through the you know, establishment and growth and sustainability of collegiate recovery programs, which are, you know, essentially recovery support services on college campuses. All right, let's see if I can get it to go to the next slide. I thought I clicked the arrow. Perfect. One nice thing too about going after Rebecca is that I could just repeat everything she said about ARS and just replace high schools with colleges, and you know, pretty much would have done the job for me. So as she mentioned, you know, part of the history of ARHE actually stems back to being part of ARS until we split off. So this April 15th date in 2010, which, you know, coming up in the spring will be our 10-year anniversary. That was the day of our first Collegiate Recovery Conference, where down at Texas Tech University in Lubbock, which kind of is the birth of ARHE as a standalone organization. The history of collegiate recovery dates back much further. In the late 70s, Brown University started a program and still has you know, a solid kind of community today, but some of the more prominent universities with longer standing programs are schools like Rutgers University and Texas Tech, both of which have been around for over 30 years. Augsburg University in Minneapolis, where I'm based out of, has been around for over 20 years. And then we really see this kind of boom of efforts and collegiate recovery programs developing in the 2000s, which we'll get into a little bit. But yeah, so that April 15th, 2010 date is really important for us, and we, you know, officially became incorporated as a, you know, 501c3 the next fall in 2011. But we really didn't have any kind of staff until 2016. I've been full-time for about a year and a half after starting off in, let's see, probably in 2014 or 2015 as a student member, and then kind of got on the board and you know, worked the way up from there. But it's really like all of the kind of success and the current status of ARHE really stems to the board of directors. And I know we have a couple of them on today, but our board, just like a lot of other membership associations, is comprised of individuals from the very same institutions that we represent. So it's collegiate recovery program staff from around the country. Just to kind of rattle off some of the schools that we, you know, currently have representatives from, just kind of going, you know, around the country. Of University of Vermont, we have Rutgers, we have Virginia Commonwealth University, East Carolina University, let's see, Mississippi State, a few schools in Texas, University of Houston, Texas Tech, University of Texas at Austin, The Ohio State University, Augsburg University, University of Denver, UC Santa Barbara. We have about 130 schools total that are members, but those are just some of the schools that are represented on our current board. So they're really the ones to thank for the kind of development and where we are now as we kind of continue to trend towards this, you know, growth and development towards being a true professional membership association for the collegiate recovery field and profession. All right, so just some kind of basics around collegiate recovery. It was, you know, funny kind of sitting here and listening to, you know, Patty talk about RCOs and Rebecca talk about recovery high schools, because, you know, a lot of the components are really the same when you're talking about recovery support services, and you know, that's really what it is. I mean, the kind of core of what a collegiate recovery program is comes down to that, you know, community of students who are in recovery from addiction, you know, like meeting regularly and being provided support services, you know, from the university, and what that looks like in reality changes a lot based on the different universities. You know, like Augsburg University, which I mentioned is in Minnesota, they have a little bit more of like a clinical type of feel. Like the students are really getting wraparound services, and have clinicians on their staff for the Step Up program, which is what the Collegiate Recovery program there is called. Versus I mentioned in that second or third bullet, Kennesaw State University, they're a full center that's kind of taken over all of the alcohol and drug work of the university, as far as like prevention, intervention, and also the recovery support services. So those components are really different at the various institutions, just like every institution is different. So there's not necessarily people always ask, oh, what's the best program? There's not really a best program. I mean, there's ones that are more developed and have more offerings, but it really depends on the student as far as what's going to be the most beneficial to that individual. But some of those kind of core components really come down to having the community of students, having staff support, having dedicated space for the students in recovery, and kind of building off that. And then as every school is different, these programs are really housed in a variety of areas as well. Sometimes it's in an academic kind of department like at Texas Tech, but most of the time it kind of falls within this broader division of student affairs, sometimes under health and wellness or a counseling center, things like that. Okay, so quickly just want to go over some of the research, because that's not really my my brain, like the academic side of things, but we've had a lot of isolated studies at different institutions, and this particular study done a few years ago by Dr. Alexander Lode surveyed about 500 students from 30 collegiate recovery programs and had some really interesting findings in there, aside from just kind of the demographics of the students and how they came across the collegiate recovery program and why it's important and things like that. There was really kind of two different findings that at least I thought were really impactful and kind of showed the efficacy of collegiate recovery. So this first one we'll go into on one of the subsequent charts, but it really looks at the typical addiction life cycle where an individual like myself, we had our first drink or drug maybe around 13, 14, and then when you get into treatment versus when you establish long-term recovery. So we'll for the sake of time, we'll kind of jump through these quick. These are the other findings though, which is really around student success metrics. So the green bar are the students who are in collegiate recovery programs, and then the black bars are the average student at the university. So a lot of this was, I mean, it's, most of us are probably in recovery and know just the potential of individuals when, they're able to, maintain recovery and kind of have that kind of grit and tenacity about life. And I think this really demonstrates that, being able to see that students in recovery, when given these wraparound support services, are far outperforming the average student at these universities when it comes to retention rates and graduation rates. The involvement chart is really around service, like community service, like being involved in that sense, and then GPA is over on the right side. So it's a really great visual to be able to see that, and it helps administrators quite a bit understand just the power of these programs. So I'm going to go back and forth with these next two slides a little bit, because this was the kind of typical addiction career that I was talking about. And thank you to Higher Ed Center at Ohio State University for, I think, taking the original information and making it a little bit more visually and aesthetically appealing. So this is kind of the typical addiction career, at least when the study was done a handful of years back, where someone's really not getting into treatment for the first time until age 31 and not achieving stable recovery until age 41, compared to the average student in a collegiate recovery program who is getting into treatment for the first time at an average age of 21 and achieving stable recovery, which I believe was defined as 5 years. So there's not really this cycle that you have in the other chart. So that what it kind of comes out to is this 15-year addiction life cycle reduction. And it's easy to talk about just numbers, but when you really think about someone's life and that 15 years that they get back, and what that's able to do for their family and for their community and for society as a whole, it just seems like a no-brainer. I mean, I was lucky to have support services when I was in recovery throughout college, in graduate school, and I went through the business school, and so this just kind of gets hammered into my head. Like, this just seems like such a simple decision for universities to be able to support students in recovery, just like they do with other student populations, whether it's veterans or students with disabilities or first generation students, international students. It's really the right thing to do, and I think we have some of that data to kind of prove it. So like Patty said, we have similar to what they have, we have a chart up on our website. If you go to collegiaterecovery.org and then go to resources and click the CRPs tab, you'll see our kind of interactive map with the different programs around the country. I think it was pretty similar to Patty's map in the sense that there's this really kind of heavy cluster throughout the East Coast and into the Southeast down through Texas. We haven't really kind of fully mapped it over another map of the colleges throughout the country, but we all kind of know that the East Coast is a little bit more populated than out in the middle of the country. So we're not sure if there's any specific trends, but that's kind of where it's been at lately. And again, you can find that on our website at collegiaterecovery.org. I also forgot to put our standards into this PowerPoint as well, but you can see those up on our website as well. So just real quickly, kind of this, as far as where we're headed next, we're kind of in the middle of this campaign about where we kind of want to see the organization and the collegiate recovery profession through by the end of 2020. And at this point, the arrows actually went away from the PowerPoint that I'm trying to click along. So let me see if I can just, oh, they're back. Thank you, Keegan. So real quick around kind of where we see ourselves moving into, in the next year and everything is similar to what a lot of the other kind of groups talked about as far as like accreditation and trainings and things like that. For a while, we were kind of this collegiate recovery catch-all and trying to kind of navigate and find our way. And our bandwidth is still pretty low with me being the only full-time staff member, but we're hoping to move towards, a point where we're accrediting collegiate recovery programs. We're kind of training the collegiate recovery workforce and, offering certification for staff and, of course, assisting in the development of new collegiate recovery programs and ensuring that, they become sustainable and really just, help move this field forward so that, students in recovery don't have to make that decision whether they're going to stay in college or pursue recovery. Just one plug for our big national conference. We do it in conjunction with Association of Recovery Schools and the Association of Alternative Peer Groups. We also have a student component, and actually this flyer doesn't even have updated language that because we're collaborating with the Higher Ed Center at The Ohio State University and having a prevention track as well. So we're really excited. This conference is pretty big, and obviously it's the 11th year for us, and it's a great time. It's the first time we'll be fully on the West Coast, so we're excited to put that together, and you can see all that info up on our website as well. I think this last slide is probably just about how to get in touch with us if you want to learn more about collegiate recovery. Those are all of our kind of links. You can shoot us an email or connect with us on Twitter. But thank you again to Faces and Voices and all the other panelists, and I'll turn it over now to Dave Sheridan from NAR.
Tim. Thanks, Tim. Now I'm just trying to click the slide thing myself here. All right. Well, my name is Dave Sheridan, and I'm kind of pulling up the end here, but I'm a executive director of NAR. I'm a NAR co-founder, and I've been involved in recovery housing for about 15 years, including work at the state level where I am in California. I'm also a board member for a 36 resident low-cost men's program in North Hollywood, California. And more importantly to me, and what motivates my participation here, is I'm also a person in long-term recovery. And I got involved in the recovery movement because I realized sometime into my recovery journey that a lot of people didn't have the options I had. and that as a funding system and a support system, most money goes into acute and subacute care, where most of the recovery happens after people get out of treatment. And that mismatch is just glaring. And I resolved that I could do something about that, and I think we have done some of that. So before we launch into what an AR is and about recovery housing, I thought I'd a slide just to define what we're talking about when we talk about recovery housing. And the first thing, of course, is it's housing as opposed to some kind of clinical facility. So people live there, they register their cars there, they register to vote there, they work, they go to school, they're in the community. The housing is focused on individuals with substance use disorders. Now, that doesn't mean that people can't be addressing other issues, but that everybody in a residence will identify as being in recovery from a substance use disorder. It's also abstinence-based, and where we talk about abstinence, we make a place for medications that are FDA approved for treatment of addiction and other conditions that people are suffering from. The other thing that really makes recovery housing unique from other kinds of shared living situations is peer recovery support. And you've heard a lot of talk, our other panelists have talked about peer services. What this means really is that people are sharing their strengths and their problems and their lived experience with each other, and really learning how to live life independently and successfully. And that really dovetails into the last essential characteristic, is that these residences all operate as family-like communities. So they're not typical boarding house situations. They're actually family-like communities. And one of the things that NAR has done that's furthered the field a bit is we looked at the entire spectrum of recovery residences that existed and realized that there's a wide variety of service models and locations, types of settings, demographics. But when we look at all the different models that are out there, they divide pretty cleanly into what we call 4 levels, where level 1 is pure peer-based recovery support services. These are households that are actually run by the residents. The most popular and well-known model is Oxford House. In a level 2, it's very similar. It's peer-directed, but there is some notion of an operator and externally imposed house rules and oversight. Most typically, particularly here in places like California, we have house managers, which are usually people that have lived in the residence for a while, maybe began their recovery journey there. In level 3, these are now residences that add some amount of programming. And this could be life skills such as healthy eating, how to balance a checkbook, job readiness. And then in level 4, we add clinical programming. So these would be services that are provided by licensed or credentialed professionals, whether they're addiction counselors or therapists. And in almost all states, that's licensed residential treatment. And these have been adopted by SAMHSA. It's okay, you can leave that slide there. Yeah, but what all of the you can see the bars below the house icons, and so they all are alcohol and drug-free living. They all are based on that social model of peer support. And then as you go up in level and the service offerings become a little bit more comprehensive, we add recovery support services, life skills development, clinical services. There's a lot more behind this but that'll give you an idea of what we're talking about. A little bit about NAR. We were founded in 2011, and it was a group of about 45 of us that came together in a hotel in the Atlanta suburbs, and we represented a lot of the existing regional recovery organizations. There were a few, and also a few people that were associated with these groups, but not necessarily working in recovery housing themselves. We're a 501c3 nonprofit. We have a 15-member board. And to echo the theme you've heard a little bit here, especially from Tim and Rebecca, we're also a one-employee organization. We've got a volunteer board and a lot of state volunteers, but I became a full-time employee last month, and so we're small, but we're growing. And we were founded in response to a few needs that had emerged and have been really apparent for years. The first was a need for a national set of best practice standards around how the recovery residence ought to be operated. And this standard needed to serve as some kind of quality assurance basis. The field was growing, a lot more homes had been opening in the last 20, 30 years. And second, there's a lack of information. People don't know where to go to find good recovery housing. And as a result, there's a lot of substandard operators that managed to stay full because they'd existed for a long time or were somehow well known. And families and individuals looking for this resource didn't know where to go. There was also a need to organize and assemble what are the best practices in operating recovery residences. There's a lot of superb operators who have been operating for decades with deep experience and connections to their communities, but there hadn't been any way to get the information that they had collected and transmitted to people who needed it. And then really the other thing that we realized as we were coming together is that recovery housing is mostly isolated. In some cases, it's literally the last house on the block, that it needed to be integrated into other systems of care and support. And so we took that on as one of our missions as well. Next slide, please. My little arrows have disappeared. There we go. So what NAR provides is that we developed and currently maintain what we call the NAR standard, which is the best practice standards for residences. We've developed an accompanying code of ethics. We defined the recovery housing spectrum in terms of levels of support, and that was that 4-level slide I went through. We've also developed a protocol for certifying residences as being in compliance with those standards. And, you know, the best standards in the world don't do any good if they can't be somehow ascertained that a house is meeting them. And following on that, we've developed a model for state and community support of recovery housing. And many states have actually now adopted that model. We've got another slide later that we'll talk about that goes into that a little bit. But the main thing that differentiates NAR from a lot of other organizations is we work in partnership with our network of state-affiliated organizations. We're currently in about 30 states. We've got some more in development. And then we do policy development, policy advocacy. We collaborate on research, and we've been part of a lot of the consortia around increasing the amount of funding that's available through places like the National Institutes of Health and NIDA and the National Institutes on Alcoholism and Alcohol Abuse to actually study recovery support services more closely, more thoroughly, including, of course, recovery housing. Next slide. There we go. And this is where we currently exist. The green states are where we have an active affiliate organization that has adopted our standards and is implementing it at the state level. It doesn't mean necessarily that the organization is huge, but it does mean that we've got a presence in those states. The blue states are where we're working with the groups in the state to develop a new NAR affiliate. And all of those are pretty active, and we expect them to be on board as full affiliates within the next year or so. The yellow states are kind of interesting. We're part of a new federal program funded by a grant to develop a center of excellence for rural recovery housing. And that's a 3-year project that's just getting underway. And those yellow states are where we don't currently have any kind of recovery housing organization, but as part of this grant, we're going to be able to help people in those states put one together. We've had a lot of success to date, but we've had a lot of help doing it. Our standards have become universally accepted and widely adopted. All of those green states have adopted them at least at the level of an organization of providers and allies in certifying homes. We're now supported by several state agencies and legislatures, and for those of you on the call from various parts of the country, we are currently, our model has been adopted in Ohio, Michigan, Massachusetts, Indiana, Rhode Island, Pennsylvania, and more recently West Virginia, Washington, Virginia, and Colorado. And this is by state legislative action, and other legislatures and states are also considering this. So we've had some real successes in that area. We've had some valuable federal agency support, and that's particularly with SAMHSA and the White House Office of National Drug Control Policy. We've got support too from organizations like you're seeing on the call today, including Faces and Voices, the National Association of State Alcohol and Drug Addiction Directors, and several others. But really our success is propelled by the grassroots advocates and residence operators at the state level and our network of volunteers. We've got a few publications that you're more than welcome to peruse on our website. The first is a state policy guide. So we developed this model for how states can develop and then support statewide networks and systems of recovery residences. And we developed this in conjunction with the National Council for Behavioral Health, which was a wonderful partner to have because most people haven't heard about us, but lots of people have heard about the National Council. Last year, with the help of a federal grant, we were able to develop a best practice guide, which for medication-assisted treatment that addresses the unique needs of people in recovery who are entering recovery with some sort of a prescription that helps reduce craving and maintain recovery engagement. It's gotten to be kind of a controversial area, but we've decided to publish a guide that distills the best practices for recovery housing providers that need to support the that special population. And then we published a guide that really explains our standard in a little more depth. Why are the rules there that we have, and an aid to operators and others who want to understand the standards a little better. But we still have a lot more to do. We want to strengthen our existing state organizations. They do amazing work, but they do it pretty much on a shoestring. And as I mentioned before, a big goal is to integrate recovery housing with other systems of care and support. We also need to expand and integrate and address support needs in the rest of the U.S. with new affiliate organizations. So we're working with 5 right now, and that's about as many as we can tackle at any one time. I mentioned a little bit the rural initiatives. A lot of our current opioid crisis and other aspects of the addiction situation really manifests itself disproportionately in rural areas. It's very, very difficult to maintain good quality recovery support services in thinly populated areas. So we're hoping that this project that we're undertaking with our partner organizations is going to help that. We want to expand training and workforce development resources so that we have more efficient ways to push best practices knowledge out to the people who need it. Again, that's particularly in the thinly populated parts of the country. We in our state groups all offer training, or most of them do, and it's pretty good, but it's very difficult to offer training that isn't place-based right now. We also have continuing challenges addressing stigma, and that manifests itself in recovery housing with local government discrimination against people in recovery who want to live together in the neighborhoods of their choice that work for them and their recoveries. It's a never-ending battle. We win more than we lose, but we can't afford to fight most of them. And along those lines, the system will be a lot healthier if third-party funding can be used to fund recovery housing stays. Currently, most recovery housing in the country is self-pay. There are some criminal justice programs. There's states like California where we've allowed counties to incorporate recovery residences into Medicaid, but the funding for that is extremely limited. And just wanted to leave this with a little bit of what we've learned and how you can help. When we started NAR in 2010, there really wasn't any governmental support or recognition except for Oxford House. Now, I should talk a little bit about Oxford House. They've been around since the 1970s, a very successful model. It's pure peer-operated housing where the residents themselves make the decisions about how the household operates, and they receive some outside support from the Oxford House organization, but wonderful model. They're all NAR Level 1 homes. Also, the recovery housing was rarely viewed by state agencies as part of their addiction strategies. Everybody knows where to find them, but they don't know which ones are good, which ones aren't good, and they're not systematically maintained as there's no way to really get people into them with the knowledge that you're sending somebody to a good home and that the home you're sending somebody to or recommending is the right fit for somebody. So that's starting to change, but when we started, there was very little of that going on. We've also found that standards adoption and accountability is greater with incentives. So as part of our implementation model, one of the things we've recommended and several states have adopted is a voluntary certification program that recognizes our standards, provides a voluntary path to compliance because of fair housing. It's not possible to require disabled people to get some kind of a license or permit to live together. But for a residence that's willing to accept standards and some oversight, there are referral preferences or funding preferences. The state of Ohio has made a great deal of funds available to open new residences, provided that the operator becomes certified by our state organization there. The other thing we've learned is that the more people know about good recovery housing, the healthier the system gets. So if you're in a position listening to this webinar of making recommendations and referrals to people to recovery housing, make sure you're sending them to good quality residences, that you've got some way to independently know that a residence is meeting some set of standards. We hope they're ours, but they could be Oxford houses. And the more people start to insist on that, we think the more states are going to start listening to the fact that they ought to really do something to support those. And if you can always connect with NAR and our state affiliates, you can find us at naronline.org, and we have a map that it's the same map as I had up there. And what you'll have is an ability to click and get in touch with any of our affiliates. And I think that's all I've got. Turn it over to Patty or
Great, thank you so much.
Wonderful. That was fantastic. I really appreciate everybody. Dave, nice way to wrap it all up at the end there. We have everybody back on video, and we're really pleased to have so many people attending our webinar today. I do know that there are 2 questions that we're going to respond to. We've decided that there are many other questions that we're just not going to be able to get to today. So what we're going to do is to answer those questions off of the webinar, and then send that to you in an email within the next few weeks. Hopefully, when you get back after the holidays, we'll have those questions responded to. But given the time, I'm going to ask Rebecca one question that was asked. Do all students that attend recovery high schools have substance use disorders? Oh, you're on mute. You turn your microphone on.
There we go, you're live.
I am unmuted now. Okay, thank you. Almost all of them do. Occasionally we'll have a student that the presenting significant problem is not substance use. We did a survey, an informal survey about 4 years ago, and close to 95% of our students across the country had co-occurring disorders. So mental health and substance use go hand in hand. So sometimes substance use isn't the primary, but it's often used as a coping mechanism. So we work with students who are, misuse is an issue. It isn't always, it isn't always full-blown addiction. Does that answer it?
Yeah, I think it did. That would, as the way I've interpreted the question, it makes sense. The other question that we're going to respond to was related to recovery community organizations and asking what the criteria are. And I had actually, Keegan, I don't know if you're still able to bring that slide back up with the 8 criteria, but it is available on our website. And the question was, there were 2 questions, 2 parts to it. It was basically, how does an organization, I guess, qualified to be an RCO? Or here it is. What determines if an organization is an RCO, and is a recovery community center an RCO? And ultimately what the answer is to that is depends on how it's run, how it's operated. A recovery community center is like a freestanding center. It's not part of a treatment center. It's part of a location where people can come in during certain hours of the day. It's they meet with the staff or the volunteers. They might do job searches at a computer station. They might go to a 12-step or an all recovery meeting, or a variety of multiple or mutual aid meetings that might take place there. So they get all of that in a recovery community center. I would say majority of the recovery community centers are RCOs, but it goes back to, is it a nonprofit organization, or is it an extension of, it could also be an extension of another nonprofit organization that's the parent organization or the fiscal agent, but it still has to be led and governed by the recovery community. So that means that there's an advisory board or a board of directors for the RCO or the RCC that is people in recovery. That means a majority, more than 50%, are self-described as people in recovery from a substance use disorder. So that's how they decide. So it would really depend, and I would encourage everyone to visit our website to see, because there's more description than these bullets here on the website to discuss it. It's very important. I think mostly what we're seeing, there's a trend now for, say, treatment agencies to open a few rooms, or separate area in their building, and that's not developed grassroots from the recovery community. They're still going to have oversight by the treatment center, and that's not what an RCO is. So I would say if there's an interest in treatment providers or a human service agency in starting an RCO, helping the community to start one, start grassroots, get a group together, get people to talk about what they need and how they're going to establish that, and it's going to have its own autonomy. So it's going to be really authentic, run by the recovery community. So there's also great research on what recovery community centers are, and that's out there by work done by John Kelly. Anyway, we're pretty much out of time. I hope that answered your question. You can remove that slide there, Keegan, and we're just going to close by thanking everyone on the panel, Tim, Dave, John, Rebecca, and for Keegan, his technical support in the background. Nice job. And this webinar is recorded, and we will have it on our website, but we'll also share it with amongst our colleagues here to distribute through your networks. I think it's time that we elevate the importance of strengthening this infrastructure as a collaboration amongst national organizations. And so very pleased to have you all here today. I think it's been very successful. So thank you all and have a wonderful rest of your day.
Thank you.
All right, bye now.
Thanks.
Bye.